Hello, everyone. It's a great day here at CCO. We're ready for another live with CCO and another excellent topic. It is the time of year. Everyone knows that we get new code drops in October, and we have been working with the new codes for a while now. We just recently had done a webinar on the risk adjustment codes. They're still going to be making some changes to that, so stay tuned. We'll do some more education on what may and may not risk adjust in the new year. However, we looked at the codes that risk adjust last year that had changes this year, expecting that they'll probably code again. Hi, Maria. That's so great to see you. Let me see. I see some other people popping in. Don't forget, it's a good time to tell us where you're from. Um, Maria, uh, I check in with her often. We're on a little chat together, and it looks like we have um, another. It's Marie and Maria and Andrea. Great lady, laddie, oh, I don't know how to say your name. Oh, shoot, that feels bad. So again, great to see you guys. It's fun to see names that I recognize. We are going to look at those new codes that have dropped, like I said. And if you guys didn't know, the number of codes was, I thought it was a lot in comparison to last year. The changes, the areas that I saw a lot of changes were in our I codes, ischemia, mostly because they added some verbiage. We got some, the dementia codes, and as I was going through and reviewing some that are not codes that I see very often or I work with very often, I was surprised how many additions there were. However, it really just means that they were adding the descriptions and broadening the description. So we'll talk a little bit about those new codes this year for 23 in ICD-10. We have over 1,176, and in changed codes there are 187. Deleted codes 287. Do know that almost all of the deleted codes are deleted because they expanded the code. And, so if you say 300 codes that were approximately 300 codes that were deleted, that means 300 approximate base codes that were expanded to split into two different codes. And then on some of those, there were multiple. So that again tells you quite a bit. Still seeing where everybody's from. And Rochester Medical Group here in Michigan. I I was in Rochester, Minnesota. When I saw Rochester, I thought, "Oh, do I know that one?" But you're in Michigan, not Minnesota. So great again to see where everybody is from. And we have people coming in from LinkedIn, YouTube, and Facebook. Again, hello. Let's see. We are not going to go over the guidelines this time. We can go over the guidelines in another webinar. There was a few changes. They kind of spelled out a few things that were a little ambiguous in the past. That's how it works. There's, for the most part, we don't see a lot of changes in the guidelines. And this year there was. I attended our local chapter symposium. I'm out of Jefferson City, Missouri. Is my new local chapter after moving back home to Missouri from Texas, and Ray Marie Ramirez came in and did an update for all of us on the changes, and she went over the guidelines. So we'll bring that to you in another webinar in the future. But for the most part, just a reminder for some of you that might be new to coding, if this is your first year to experience changes, know that how you do that is you look at the guidelines in your manual, and anything that is in bold is new verbiage. So it's pretty much as simple as that. You can compare the old and the new if you want to, but it'll be in bold lettering, except for the headers and stuff. All right. We are going to use Find a Code this year to look at the changes. You know, I like Find a Code. I know last year I spent a lot of time dividing up and color coding the new codes, the old codes, the revised codes with specific colors. And then I went and did some specific education on some of the disease processes, and that worked out really, really well. But it's very, very time consuming. And ultimately, you guys, this stuff's in your encoder. At least it is in Find a Code at your fingertips. And so, what I'm going to do is we're going to break down uh, that versus using a slide deck. So, I am just going to get out of my main screen here. Whoops, I didn't mean to do that though. Let me get my X out here. And let's go look at the new codes. Now, what you do for Find a Code is we go to the ICD-10 and you scroll down here, and all of the new codes are set up. We have new codes, changed codes, deleted codes, the reactivated codes. There's none in there, by the way. Past changes per year. I can go in and look and see what was changed from last year and the year before. And but what's nice, if we go in and we look at a code, we can actually look at the history of a code. I'll show you that because I did research that on a code that I was kind of curious about. So in this field, I have the new codes. Here I have the codes that were changed for the year and the deleted codes. And in addition, if you wanted to know how I knew how many new codes there were, it was because I sat down and counted them one by one. No, I didn't. That's just insane. No, I looked right here. There are 1,176 codes in this list. And what's brilliant is they are alphanumeric. So I know if that by just looking at this list, there are no A codes that had changes. The very first code was B37.31. So again, very, very easy. Another reason that it's really nice to have an encoder that has this information for you. Just know that, again, the Find a Code isn't paying us to do this. This is just the encoder I prefer, but that the they also have information about the risk adjustment codes. It makes it so much easier for us. So let's get to it. Let's look at the codes. The very first thing is that we have a division of candidias, which is just yeast, of the vulva and vagina, and it is now further described as acute or chronic. Excuse me. That's how they expanded it. Very simple. We have those options now. But that also means that we need to educate our providers to let them know that the code set has been expanded and that we would like to have that in their documentation of acute versus chronic. If you let them know ahead of time, that within the code set, there is a lot of new additions for conditions that are now acute and chronic, then they'll have a heads up and they'll be more mindful to put that in the documentation because they're thinking it in their head. But we can't define something as chronic unless they state it's chronic. Uh, acute might be easier as it is the first time that a person gets this diagnosis, if you want to consider it that way. I'm still watching everybody talking to each other in the chat. That is a lot of fun. All right, moving on. We go all the way out to decodes now. Decodes, they made several changes in hemolytic uremic syndrome. Now, let's break this down. Let's look at what decodes are. Decodes are going to be anything that has to do with the blood, more or less. I mean, there's more, the lymphatic system and blood. Let's see if I'll show you how you can do this quickly. I just open this up. Let's move it over here, and you can pull your manuals out, and it's diseases of blood and blood forming organs. Hemolytic anemias, acquired hemolytic anemias, and they have expanded. You see, all of these codes are new. They further defined them as infectious associated, hereditary, and other. So, again, that was a really interesting expansion. I'm going to just X out of that. And then we go into von Willebrand disease. They expanded that to give us type. And notice that expansion always includes unspecified and other. So whenever they make a change, there's two right there. But we have type 1, 2, A and B, etc., type 3, and acquired von Willebrand's and other. Now, what do you think von Willebrand is? Let me just break this out and give you a little information. We talked about this in another lecture on how the disease is done. If you weren't familiar, type 1, 2, and 3 is defined here, which is really nice because to have this in your encoder, because your manuals are not going to tell you this. It is a bleeding disorder, and it just shows severity to give the way that it's divided up in blood disorders. And then we get straight from that into thrombocytopenia. Notice that in our thrombocytopenia, we have new codes for heparin induced. Now, they added several. We have one, two, three, four codes. We have the non-immune heparin induced. We have immune mediated, and then other, and then unspecified. So if you don't know what heparin does, heparin is like a thinner of the blood. They often put heparin's used when you get an IV. They give you heparin to keep that IV patent and not getting blood clots and stuff. They'll put a little heparin in there. But this also gives you information about type 1 and 2 autoimmune and spontaneous that's built into the code set, if you weren't familiar with that. Now, one of the things that we like to do with our webinars is, if we're going to be very, very specific about something, we'll narrow focus and we won't do a broad webinar. This is a really, really broad, and we could talk for several hours, at least, I could, about this information. But I'm going to drill down and give you the basics so that you can in turn go and do more research. So if you, again, weren't familiar with von Willebrand, then you can write that down and you can say, okay, I'm going to go look at von Willebrand. Or maybe thrombocytopenia is not something that you were familiar with. It actually does risk adjust, so I pay attention to it. uh, but that will be a launching point for you. We're really into education, and we don't want to just spoon feed you the information. We also want to have you go out and do the research. And if you ever have questions, you can come back and ask us, and we can tell you how we research, or even us showing you in these webinars is a great way to see how we do it. But again, it's one of those, teach a person to fish type thing. You'll be researching the rest of your life. D codes, there's only 2 D codes left. There was another platelet activating disorder, and then APDS, which is activated phosphophenoside 3 kinase delta syndrome. That's just fun to say. Then we move into our E codes. Notice we have further definition for short stature. How come a person has not further developed, possibly, or what is the reason behind it? And I think this is really very interesting. Notice that these are E codes. Why do you think that they put those in an E code category? Does it have you What are E codes? Those all have to do with the glands. Now, we usually remember endocrine because E codes, diabetes, that's how, when you're first learning the code set, you think of that. But again, our glands will determine our height. So if a person has, say, a tumor on a particular gland, I'm really curious if you guys know which gland I'm thinking of, that will affect your height and your stature as you're developing and growing. If a person has a cyst or a tumor, or there's something wrong with that particular gland, it will stunt your growth and make you short. Uh, so again, put in the chat, what do you think that is? And Jane had said, yeah, endocrine gland hormones. So we have further definition here. E34.30 is short stature due to endocrine disorder unspecified. So we don't know what the endocrine disorder is. Yeah, it's pituitary gland, right, Jane? And then constitutional short stature. Now we have primary insulin-like growth factor, IGF-1 deficiency, and resistance was now built in. Other genetic causes of short stature, and then unspecified, and other short stature due to endocrine disorders. So they really made that more robust, didn't they? They gave us a lot of codes to define that. And I suspect that we'll see this in pediatrics a little bit more. So if you are working with family practitioners or pediatrics, letting them know that the code set is more robust to explain why maybe one of the children that they're working with, one of their patients has stunted growth. Then we jump down, we're still in E codes, acidosis. We have acidosis unspecified, but we have also now acute metabolic, chronic metabolic, and other E87 codes. If you're not familiar with acidosis, again, we think of that with ketoacidosis. A diabetic type 1 especially can go into ketoacidosis, but this is acidosis. Uh, uh, you wouldn't be a diabetic, because notice here we have that in an excludes one. And that the new code, the E87.20, is going to include lactic acidosis and metabolic acidosis. And then here's further definition about acidosis if you weren't familiar with it. So I thought that was kind of cool. Moving on now into the F codes. You guys, the F codes took a huge hit in additions, meaning I guess that is the opposite of what I'm thinking. They are extremely expanded, and I can tell you why. Because they added they described the behavioral disturbances. Now, we talked about this a lot the other day when we did uh, a video on risk adjustment codes that were expanded for the new year. And again, it was just a heads up, a brief. In fact, I think that might be a club exclusive. Sorry about that. But if you're involved in risk adjustment, then dementia is something that you see quite a bit. Now we have further specificity as to what type of behavioral disturbance it has. The new additions include, and first you have to break it down, is what type of dementia did the person have. So the very first one on the list is vascular dementia, and then it goes through and describes all of those types of dementia have this behavioral disturbance added. So we have with agitation. Every single one of those got with agitation, with other behavioral disturbances, and with anxiety. So, what I'm going to do is just expand here and let you see this description. All of this right here is new. And it don't let that overwhelm you, because if you just go to take out the major neurocognitive disorder due to vascular disease, unspecified severity, with this is the information that's new. Let's see if I can get this. With ah right there. With aberrant motor behavior such as restlessness, rocking, pacing, or exit seeking. Okay. And then they expanded verbal and physical behaviors such as profanity, shouting, threatening, anger, aggression, combativeness, and violence. Now, and then notice it's just repeated for major neuro cognitive disorders and also vascular dementia. That is added to every single dementia code. Those components have been added. Well, almost every single one. This was something that I know while doing provider education, a lot of our providers asked about. They were a tad bit confused as to, what code would fit, because they're forced to code now a lot. What code fits what they're trying to say? My patient has this particular behavioral disturbance. Where does that fall? I don't know where to put it. So they defined it. They actually spelled it out. So all of these that I've described are applicable to this F01.511, and it's unspecified severity, which we have specified severity within there. So ideally, we need to let them know. We need to know the severity, and then got mild, moderate, and severe. Then that's been expanded upon. So that is a lot of codes. That is, I'm not going to count them, but look, we start right here to F01.511, and it goes all the way down all of these dementia codes. Look, I'm still sliding down the scale, and you can see why now I didn't want to put all this on a slide deck. Can you imagine trying to get that divided up into multiple slides? Still going through these dementias, and all they did was they expanded the behavioral disturbances, and still going, and all the way down to F06.71. Again, there's a lot of different types of dementia, and then we had to add all of that with anxiety, with mood disorders, etc. in there. If you guys have any questions about that, I've been doing a lot of lectures on dementia lately. Feel free to send us a note in the forum, or better yet, if you are in our CCO club, we can talk about it there. Hey, look at that person's name is highest specificity. That's pretty cool. It says, would that specificity be in the assessment, or is it seeing it in the HPI enough for risk adjust? Depending on who you work for and what your risk adjustment role is. If you're a production coordinator for an MA plan, probably in the HPI is enough. Again, it really just determines, or wait, she says, oh, Jane's got a question about social determinations. We'll look at that at the end. Okay. All right, so now we're moving on to use, abuse, and that every single one of our uh, dependence, chemical dependencies, was added. What we now have is in remission. This was added to every single one. If it wasn't already there, in remission. So again, just like our dementia, they expanded the use codes, and there is a lot of them because we have alcohol, opioid, cannabis, sedative, sedative, cocaine, other, hallucinogen. Look at all of these. So we start out at F10.90, and we keep going all the way down to F19.91, other psychoactive substances use unspecified in remission. That's what they add, that verbiage, which is excellent. And in turn, what does that mean? You need to let your provider know that the our already robust code set has been expanded to include this so that it can be tracked. Absolutely. Jane says in remission means doc must write it, or if patients stop after a certain time period. No, the provider has to document in remission. Just because they have been exposed or to using or whatever, it has to state in remission. You cannot pick an in remission code without querying the provider to get, and go through proper query protocol. But again, let them know, heads up, this in remission is now available to them to describe, and then they can define that. I also want to say, guys, that if you're in a setting where maybe you can't query, then you need to come up with a policy within whatever department you're in, or where you work at, and say this constitutes this definition. When we see this documentation, then we're going to define it as this code or this code. And then everybody's all on the same page. And then if it's wrong and they come back and tell you, like they have a RADV audit if you're risk adjustment or something else, just a compliance audit or something, then you can say, hey, we were consistent though. This is the way we understood this to be defined so that we could translate it. We wrote it down in our compliance notebook. We all did education. We're all on the same page. You're telling us that it's incorrect, so we'll correct our ways. We'll change the way we translate, and we'll educate, and so on and so forth, and then you won't get in trouble. But so if you're ever in doubt, don't ever take the word for someone, even like me saying, no, in remission only means XYZ. No, you guys have to, wherever you work, has to come together and have compliance sit down and your providers and say, this is a new code. How do you define remission? And make it a policy procedure type thing in your manual. And then nobody will get confused. All right, moving on to prolonged grief disorder. Now, this is actually a new code. This is not a code that was expanded off of anything else. It's actually a new one. So prolonged grief disorder, and then they also included other reactions to severe stress. Uh, Again, that's new. So let's just kind of go and look and see. This means complicated grief disorder, persistent complex bereavement disorder. And then it went on to describe uh, uh, how they define that. And I know that several of the codes that we saw had some DSM-5 quotations and things in there. You probably don't have access to a DSM-5, however, because they're extremely expensive, but you can usually get the information somewhere. Oh, Sarah has a good question. Uh, how often does risk adjustment get audited, like maybe from capitated payer Humana? A lot. They not only does the payer audit out the from a federal standpoint, RADV audits come in from the feds. They're paid to find mistakes. And well, so like if Humana comes in and comes in and audits, they can drop a contract with you if you make too many mistakes. Some of the providers, they say, you're costing us too much money because you don't document right or code right. Okay, so moving on now to G codes. G codes always have to do with the PNS and the CNS, right? Our little gray cells. That's how I remember it. They had several additions with muscular dystrophy. This is not an area I am that savvy on. And so what they did was they added these um, autosom- autosomal small, I can't pronounce it, dominant limb girdle muscular dystrophy. And notice here they've described the different types of MD, and we have multiple of them. So we go all the way from G71.031, and still all of these are types of muscular dystrophies, to G71.039. So there's multiple of them. Then we go into POTS syndrome, posterior, it's tachycardia syndrome, POTS syndrome. This is a condition. POTS by itself has been available to us, but it was actually in another code, I think is the way it used to be. And now POTS has its own code. I think, I had to do a little more research on that. I can't remember. I know we used to use POTS. I think it was included into another code. But POTS is it has to do with the CNS, and what most people know of POTS is like older people, when they stand up too fast, their blood pressure drops real fast. Well, in actuality, it has to do with the brain, not the vascular system. It's the body telling it what to do. Oh, Karen says they usually do provider education with providers before they would drop providers. That is a good point, Karen. They don't just say, hey, you've been naughty, and drop you. They try to educate you. They give a lot of free education. I know some people that work for some payers that do provider education. And in fact, if you want some good education on certain scenarios and risk adjustment, you can jump out to things like Humana and UHC, and they will publish provider education. So I use them as a resource finding things. Yeah, orthostatic hypertension. Karen, you're right. It's under orthostatic hypertension, and now it has its own code for POTS. Thank you very much, Karen. All right. I knew it was in there somewhere. It just didn't come off. Now, notice here on our G codes, we jump over to G93s, and it's a fatigue syndrome. They've expanded it to post-viral. They have encephalomyelitis. They have other post-infection and related fatigue syndrome. I think that's kind of interesting because have you heard that the COVID and the long-term COVID, some of the symptoms that have hung on, and that fatigue, we have to remember COVID is a virus, and so post-viral fatigue syndrome, right? Other post-infection related, I think that is really, really cool. So again, cool stuff. And that's what they do. The code becomes more and more robust to fill the needs of the diagnoses that we have to capture at a high specificity. Why? Because we have to track them. All right. And then we're going to now go from our G codes all the way to our I codes. There's several of them. The first one is refractory angina pectoris. So now refractory was added. Because that was added, I20.2, that means that any other code that had a type of angina associated to it gets expanded as well, because we have a new code for a type of angina, and refractory is one. So thus, look at the very next code, I25.112. That means that all of our CAD codes that had with or without angina, remember? So then they had like an other unspecified angina, unstable angina, and there's one more, I think. Now they had to add to every single one of those refractory, because they created a code to describe the new refractory angina. So you'll look, you have CAD of the native coronary after bypass, then you're probably recognizing these point 0.1 codes, point 0.7. Some of these I have memorized because I use them so often. And every single one of those now had to have refractory angina added to it. So CAD codes are now expanded. Makes perfect sense to us, right? Um, okay, now we're going to go into uh, further I codes. We have malignant pericardial effusions in diseases classified elsewhere, I31.31. And then, of course, because of that, we have 0.39, other pericardial effusions or non inflammatory. Then still working with the heart, if we have a non-rheumatic mitral valve calcification was added, other than non-rheumatic mitral valve disorders. And then looky here, which I thought this was really, really interesting, ventricular tachycardia unspecified. And you think, wait a minute, what happens? We've always had that code. But the reason they expanded it. So we had I47.2, but now that was deleted. We don't just have VTAC anymore. We have unspecified tortoise de points. I don't know how you say points French. Point. I don't know if the T is silent or what, but this is like a twisting, and 29 other ventricular tachycardia. So we don't just have VTAC, we have more expansion. And I used to see this on a lot of reports. So I'm glad that now we have a specific code for that, and what remains to be seen if it will risk adjust or not. Moving on now, another huge area that was expanded, brilliantly so. One of the areas that is a often missed HCC, and again, I know you guys may or may not get tired of me talking about risk adjustment HCC, but that's what I really enjoy. So I kind of divert my brain, kind of swims in that area anyway. We have always had this aneurysms and dissections and ectasia of the aorta. Uh, and a lot of times it's a missed HCC because again you have to be capturing it every year, and they'll see them on the CT scans and stuff. The radiologist will notate it when the person comes in because they are having a chest X-ray or a CT, they had pneumonia or something else going on, that's not the reason why the patient was being seen. So the provider doesn't document it, and it gets missed, and it's not tracked, and so on and so forth. So let your providers know that the code set now allows for these aneurysms, ectasias, and stuff in specific parts of the aorta. Now, before we've always had thoracic and abdominal. That was it. You could have thoraco-abdominal aneurysm. So you had three. Blew that out of the water. Now we have let's see, ascending, we have the aortic arch, descending thoracic. Uh, let's see, we also have, let's see, ascending. Okay, every one of them got added. With or without rupture was already in there. So now we have, again, let me back up. Ascending was added, aortic arch, and descending. See, thoracic aortic aneurysms, abdominal, pararenal was added. This juxtarenal I would pronounce, I don't know if it's renal. I don't know if the X is pronounced as an S. I actually have never seen JUXTA before. It's not that I didn't see it before, I've just never paid attention to it before. So obviously it's a part of the renal aorta area. We'll have to look that up. I'll write that down. Uh, Infrarenal, I knew about, that's expanded. And let's see, abdominal aortic, pararenal, I knew about that one. Okay, and then we got the same one, that new JUTSI. Infrarenal, thoracoabdominal, they kept that. Supraciliac and paravisceral. And then we got our thoracoabdominal, superciliac. Again, we got with or without. So again, look at all of those expansions and word descriptions so that you can uh, identify exactly where that widening is. Uh, is widening a word when that way, saying it that way? I think so. Very, very cool stuff, right? Oh, right. Let's move on. They did add this ANCA vasculitis is now there. And we then move on to J codes. We have one J code. It is transfusion associated dyspnea, TAD. We didn't have that before. If you don't know, people get transfusions and all kinds of things can happen. They can become short of breath. They can get rashes. They can become lethargic. There's just, again, a lot of things that can happen to them. So J9 5.87, they start having trouble breathing after a blood transfusion. We have only one K code, hepatic encephalopathy. Then we go into M. M was expanded again, very large expansion, intravertebral annulus fibrosis defect, lumbar region unspecified size. And then notice that we have the defect that it is unspecified small or large. And then for the lumbar region, then it goes lumbosacral, and it starts all over, small, large, exact, and it just keeps expanding. So if you work with intravertebral uh, problems, then that will be new for you, expanding. Then we go into muscle wasting and atrophy. And then they define where that's happening. And they've got cervical, thoracic, lumbosacral, which is low back, lumbago, remember? And then we move in to M93 now. Slipped upper femoral epiphysis, non-traumatic, and acute slipped um, bone in that joint. And that is the top of the bone. You know, it pops out, that little top of the bone. All right, let's move on. Those are just expanded. We've got stable, unstable expansions. Notice there the key words, and just know that it goes through all of those bone joints. So we're going to clip through there. Oh, the flail chest. Sorry, I may sneeze here. I can feel a sneeze coming on. Hold on just a second. Oh, I won't sneeze in your ear, baby. Okay, that was not very exciting. All right, notice here, I forgot about this one. Because when you give CPR, especially on older patients, it's just a classic thing, you crack ribs. That I had one uh, um, EMT instructor tell me that if you don't hear the snapping of the ribs, you're probably not doing it right, which that was a whole long time ago. But because that is something that happens, then we have fracture of sternum associated with chest compressions, and that's CPR. And then not only do we have the sternum, we have one rib, we have multiple ribs, we have flail chest, which is really actually pretty fascinating. I know how to treat that if it happens. But say your sternum's right here, and these are your ribs attached to your sternum, and that means all of the ribs detach from the sternum or your breastbone, and then that breastbone is just floating on top of your heart and your lungs. And actually, the way you treat that is you put pressure on it. You just put a sandbag on the chest, not a great big giant sandbag, but anyway, I always thought that was because it seems counterproductive. Okay, so now we have a diagnosis code to describe what those fractures. Again, it's so common, so now they want to know, track that, and maybe because of that, we'll be able to come up with devices that will prevent that. Mm. All right, then moving on to encodes. Contrast induced nephropathy. We have a couple codes here for this nephropathy induced by something, some type of chemical. They literally mean the contrast that they use when they're doing scans. And then we have Fournier's disease of the vagina and vulva, just an encode off there by itself, kind of um, um, one off, I guess. Then we go straight into endometriosis of the uterus. Then they further divine that. Look at N80.00 all the way. Again, look at all of these endometriosis codes. Superficial, deep, goes, I'm still going. All of these are endometriosis codes. And it's still going. You can imagine why I didn't want to put all these, try to get these on a slide deck for you. This is so much easier to give you. One thing, if you don't know what endometriosis is, it is the lining of the uterus, that tissue on the inside of the uterus, showing up on the. It can show up anywhere inside the abdomen. So that's what they're defining here. Uh, Still going in 80. Look at all of those new codes. Still going. It beat the behavioral disturbances, right, for dementia. And I think nope, still going. There we go. Uh, it stops here at N80.D1, uh, and endometriosis of other pelvic nerve. And then we have the isthmosal now, N85.A. We did get several obstetric codes. Notice the first one here, these 035. It starts with an O for anybody that's new to the code set. It is going to be a maternity code, maternal care for suspected CNS malformation of damage in fetus. And then that is expanded because we can have that for one baby, or how many gestations do we have? We could have multiple babies up to five, and then it goes into other, and then it goes into after what that uh, notice here we go into a genus of corpus cas- callosum. Some of those I may not be pronouncing very well. And then that gives you all the codes, because you have to have multiple, be able to have assign for babies multiples, encephaly, and then carotid plexus cysts, just all of these encephalocele, I don't even know what this is, uh, holoprosencephalopathy. That was tortured. Oh my word. So I'm just going to swing through these now that you know that these are suspected codes. Oh, Johan says, do we need to code an additional adverse effect code for the contrast-induced nephropathy? Most likely, yes. Let me just go look real quick. I do believe that that was built in. And let's see if I can find that in, oh gosh, we got to go way up. In nephropathy induced. We'll just go look, but I am almost positive that you will. Good point to make. Yep, poisoning due to drug or toxin code adverse effect. Right there. Good catch, Johans. Johann, not Johans. Sorry about that. Yes, good catch. Okay, back down to all these O codes. Again, do your own research on those. We're going to slide through those. As you can see that we have maternal care for all of these different types of scenarios. And then we have to add 6 codes for one baby all the way up to 5, and then other if you were to have more than 5, and then unspecified. All of those codes are in there. And then we go straight into the P codes. And with those P codes, we are dealing with the children. These are pediatric codes. And what are we getting there? Sleep apnea. We get uh, primary and other sleep apnea. I'm really thinking that eventually OSA is going to risk adjust, even if it's not, if they classify it as an RX. I don't know. All right, then Q codes. We are getting some of those congenital codes. Atrial septal defects has been further defined. We used to have it as Q2 1.1. Now it's 0.10. And after that, they have defined all the different types of septal defects that um, uh, can happen. So that's what these all are, these Q21 codes. Then we jump into a PTN, tumor syndrome, some Cowden syndrome, the von Hippel, Lindau. What they did was that we had, I think it was Q85.80, and then they got rid of that code and they broke it down to all of these types of that particular PTEN. And this phacostomosis is one thing I can say. Oh, right. And yeah, Jane, sleep apnea for newborns. Who'd have thunk it, right? Then the S codes, we have some new concussion codes, and then traumatic cerebral edema. Um, they added that with loss of consciousness, status unknown, sequelas, again, the traumatic brain injury, they expanded upon that. Lacerations, hemorrhages, and again, that's pretty extensive. Now, if you're doing ER work and stuff, neuro, then you'll probably be seeing most of those. I'm going to skim through those. Primary blast injuries of the brain. All of our guys coming back are veterans coming back with these injuries. Makes us think that's probably what some of that is about. And then we move into T codes. Poisoning by methamphetamines. Before we didn't have methamphetamines by itself, so we got now all of those codes added with the initial subsequent sequela, as well as intentional, unintentional self-harm, assault. All of that is expanded. And notice all of those codes right there were for methamphetamines. Moving to V codes, electric assisted bicycle driver injured in collision with pedestrian or animal in non-traffic accident, initial encounter, subsequent encounter, sequela, and then they also added the other motorcycles, as well. Then they electric assisted bicycle passenger, and they go through the whole gambit just like they have other times. So all they've done is added these electric type bikes, and then everything that could happen that you saw with, say, a motorcycle is now listed, and that's why these are very huge additions. um, these V2O codes. So we'll skim through those. You can take some time to more electric bicycles collisions, because remember, when they are defining those for statistical purposes, it's what is it that the patient, the person the was driving or in. So like I said, this is electric vehicle, and then or motorized vehicle of some kind. And then they have to define, were you the driver or the passenger? And then if it is in traffic or not in traffic, then they've got to do the initial counter, subsequent encounter, sequela, or unspecified. All of that stuff has to be included, and therefore it's expanded. So there, all of those are electric or other new motorized bikes, right? So we can go all the way through those. That'll just about wrap us up. These new electric vehicles added, and I'm going to skim down very quickly now. I think I thought there was one down here at the end that I wanted to bring to your attention. Oh, here it is. Getting into the W codes. So with our W codes, we have caught, crushed, jammed, or pinched between moving and stationary object initial encounter. They expanded that. And then subsequent and sequela. And then observation for suspected conditions related to home physiological monitoring device ruled out. And then we jump into our Z codes: transportation insecurity, financial insecurity, marital hardships, et cetera, et cetera. Uh, encounter for pediatric to adult transitioning counseling, and then counseling for socioeconomic factors. Remember what we're doing, those quality measures that have popped out for a while. Bree says, thanks. My job is re-airing to educate for our providers and staff, but AMA has to come better with the data element. Yeah, majority of IP patients have labs ordered every day and separate specialties to review. You're right, Bree. Whew, that's a lot of work too. I know it. Okay, then we get into let's see, those risk of suffocation or smothering under another while sleeping. Never had that before. Long-term current use of immunomodulators and immunosuppressants. And then there's some additional biological type things there. More inhibitors that are being used. Notice now we have long-term current use of insulin. Then they added anticoagulants, and then they added oral anti-diabetic medication, and then other medication. These different therapies. They've added more. So now we have these nucleotide synthesis. We have alkylating, let's see, anti-metabolite, I'm not going to read, anti-tumor, all of this stuff, myelosuppressive. Wow, there is a lot, isn't there? Now, look here. This is pertinent to us. Long-term current use of injectable non-insulin anti-diabetic drugs. Of course, this isn't going to risk adjust, I'm sure, or maybe it will, but there sometimes new coders get confused. Long-term insulin is, just because they're injecting something doesn't mean it's insulin and they're diabetic. There are some non-insulin injectables, because back in the day you could just say, okay, if they're injecting them with something and they're diabetic, most likely it's, but not anymore. And then we get into some personal history codes, and then I'll let you go through those. They're kind of interesting, but but I did look up prune belly malformation because I had not heard of that before, and it's quite interesting. And I went and looked at some pictures, and um, they do. They look like little prunes. Their little bellies look like prunes. The muscles don't develop to hold the all the abdominal. The abdominal muscles don't develop. It's all pruny. The skin is, and then if you live, then your abdomen has no support. Johan, yes, non-injectable, non-insulin injectable like Trulicity. That's exactly what I'm thinking of. Yeah. Yeah. Alexandra says, so glad I came across this tonight, and I'll have to add this to watch the day off and Sunday. You're right, Alexandra. I am so glad that you're here. And I see you're a CPCA. We love to help CPCAs. So stay in touch. We give a lot of free education out. Okay, then we got some more Z codes for non-compliance things happening. And notice that why is the patient non-compliant? It's just not because they're stubborn. It could be financial hardship, other reason, unspecified reason. So they added all of those. Caregiver intentionally underdosing patients medication due to financial hardship. We read about that a lot. The providers will say the patient is no longer taking all of their insulin because of their expense, and or the wife is giving her husband a pill every other day because they can't afford to get the prescription. And it's not that they're trying to off their spouse. It's because they literally don't have the money to purchase the medication. And most of the time you can speak with the doctor, let the doctor know, and they can figure a workaround, whether there's scholarships involved. A lot of pharmaceutical companies have scholarships, but there may be another medication that is not as expensive that can be used. So again, that is something to think about. All right, so that was all the new codes. The changed codes, 187, but when you go and look at these, most of the time they're not there. They are verbiage that has changed. So they didn't expand the codes and stuff. So now C61 now says malignant neoplasm of the prostate. And then you notice some of these codes, the lymphoma codes change, uh, qualitative platelet defects. See, and the dementia. Um, these are just changed descriptions. The description was, the code stayed the same. Huntington's disease, Parkinson's disease stayed the same. The description and the verbiage within it changed a little bit. Like, let me see if I can pick it out by memory. It could have been just that they added one of these on there uh, to further define it. It's pretty simple stuff usually, so we won't go through those. And deleted codes. Now, this is again something that we can go over very quickly, because you notice that the very first one that we look at, candidiasis of the vulva and vagina, it was deleted. Why? Because they expanded it, and now you have acute and chronic. Very simple. And you will know hemolytic uremic syndrome, deleted. Why? Because they gave us like 4 other new codes to further describe it. Von Willebrand, we used to have one code, D68.0. Now we have like 5, because there's different types of von Willebrand. And again, heparin-induced thrombocytopenia, now we know that it is further defined as additional types of heparin-induced thrombocytopenia. Short stature due to endocrine disorder, that's what we only had before. And now we have multiple further descriptions. So again, we won't go through these because these are deleted codes that were expanded to further give acuity, type, and sometimes even severity added to our code description. And that's it, guys. You know what? We have a lot of fun with our webinars. Our CCO lives are a little more casual, kind of fun with things, but we still always take your topic requests, especially if you're in our CCO club, into account. We're already planning out for next week and took them directly from questions that were asked, or somebody wanted us to break down a topic, further highlight it. We do advanced topics as well as basic topics. Again, we also have courses that you can come to us. We hope that you will take some time to look at our proven process and see how we think through over a decade of education what works really well. And again, our goal is to help you pass your credentials. If you want more information about our CCO club, you can go to the cco.us/club. We always take the club members' requests in priority. And a lot of discussions go in there. And sometimes we'll take discussions from in there and say, hey, can we explain this in a webinar? This will take too much to explain just typing it out. But hopefully this was beneficial to you. It's a lot of fun to do. And if this was helpful, don't forget, like, subscribe. We don't really do any advertising. It's mostly word of mouth. And we would really, truly appreciate it if this was helpful to you. You tell everybody you know so that it will help support us. All right, guys. Thank you. And I'll see you next time. Bye.
Do you need more medical certification and business training? Learn more at www.cco.us.